Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this hour with us, and we hope that you will find it helpful as well as hopefully a little bit entertaining. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Neighbor-Stevens, and thank you, Dr. Ivan Walks and Dr. Jocelyn Hines. We do have a very interesting program for today concerning update on respiratory viruses. But before we get to that, I promised to make an announcement that Region 6 of the National Medical Association is having a meeting in Beaver Creek, Colorado. And it's going to be April the 24th through the 26th. And 26th rather through the 28th. And we're inviting all interested people to come. And we'd like you to consider that. And there'll be interesting paradigms of health disparities discussed at that meeting. Our speakers today are Venerable Dr. Barbara Neighbor-Stevens, board-certified pediatrician, formerly faculty member at Meharry Medical College, and everyone knows Dr. Barbara Neighbor-Stevens. Whenever I need advice about my grandkids, I get her on the line, and she gives me the best advice you can think of. Our other colleague, our junior colleague, is Dr. Jocelyn Hines, and I had the honor of meeting her a year or so ago, and I was surprised at how young she is. I would say almost like young as my daughter. And she's a brilliant family practitioner, practices in the state of Maryland, and she does family medicine there. She does academic and administrative medicine in the field of family practice. And she is tangentially related to the famous Dr. Ivan Walks. So today we're going to introduce these two young ladies to be with us and speak about updates on respiratory viruses. And I won't try to spell the word syncytial. Dr. Stevens.
Thank you. Simon, let them roll, please. While Simon is setting up the slides, I'd like to kind of explain where this whole thing came from. Now, we are going to talk about diseases for sure. But what spurred the thought was when the CDC came out with its most recent COVID recommendations. And I don't know if any of you paid attention to how they presented it, but it was clear to me that they are still smarting from what happened with the way they handled COVID-19 during the pandemic. And as we go through all of this information, in the back of your minds, I want you to be thinking, we probably won't discuss it, but I want you to be thinking about, is CDC and US public health entities, are they really now serving our health needs, or have they been cowtied and beaten down and pulverized by the experiences in the pandemic and since the pandemic? So today, we're going to talk about respiratory illness updates, because there have been some things that have changed since we gave this some serious conversation. And please, as always, if you have questions, put them in the chat or raise your hand, and we will go through the information and hopefully have an interesting conversation. Next slide, please. So this is the spring, and you're probably thinking, why are we talking about respiratory illnesses now? This isn't October, November. We're not going into winter. Why are we talking about this? Well, for lots of reasons, not the least of which the nature of viruses, which have their own way of doing things. We have somewhat of a changing landscape in terms of respiratory illnesses. Some of the illnesses that we used to think of as primarily being fall, winter kinds of illnesses are now showing up in the spring and the summer, and vice versa. And I thought I'd just share with you this pretty little graphic showing current respiratory illness activity in the United States. And I should say that the information contained in this presentation, for the most part, except for one which is labeled, came from the CDC. And so depending on the color, you can tell the level of activity, with the highest levels of activity being the darkest colors. So you see, there is, except for one area that they didn't have sufficient data, maybe half of the country is seeing low levels, that being the greens, but the yellows and oranges and reds are still quite prevalent. So we're not out of respiratory illness season. Next slide, please. Let's talk about COVID today, here in the spring. Right now, Omicron JN.1 is the predominant variant, with it representing 93% of the identified organisms in lab tests. We have the new well, it's not new now. As of the fall, we had a new bivalent vaccine. Everybody was worried, was it going to be effective? Well, the studies are showing that it has been effective in reducing severity of infections, and it has also been effective in minimizing the symptoms when you do have an infection. But then, I guess 3 weeks ago now, the CDC came out with some spring recommendations. Next slide, please. And as you recall, the CDC had recommended for the 23-24 season, the bivalent ones, which are listed here. Everyone aged 5 years and older was, and you notice their choice of words, should get 1 dose of an updated COVID-19. So what that meant was, irregardless of whether or not you had vaccines prior to last fall, everybody was being urged to get, everybody 6 months and older was being urged to get the new bivalent vaccine, which was became available, if I remember correctly, at the beginning of September. Now, they are saying that, next slide, please, people who are moderately or severely immunocompromised should seriously consider getting an additional dose of the bivalent vaccine. And I put in red the one that triggered all of my thinking, which was that people aged 65 years and older who received 1 dose of any updated 23-24 COVID vaccine, any of the 3 or 4 that were on the previous slide, should seriously think about getting an additional dose of an updated bivalent vaccine at least 4 months after the previous updated dose. So if you got your shot in September, October, November, December, anytime after December, they're saying you should seriously consider getting a second dose. Now, our audience knows why. We've talked multiple times about how the body mounts an immune response, but it does not necessarily sustain the levels of antibodies to sustain the preventive effects of the vaccine, which is why, if you recall, back in the 2 years of the pandemic, we were getting COVID vaccines almost every 6 months or so. So the recommendation is that we get that second bivalent if you're 65 years or older, and or if you have any immunocompromised condition, with anticipation of the arrival of the 24-25 vaccine around September, and the need to get that vaccine as well, which we will talk about closer to the time. But it was this recommendation, and I heard people questioning whether or not, even if they met the criteria of being 65 years or older or were immunocompromised, whether or not they should get this booster. You could kind of think of it as a booster dose. And we've talked about booster doses in the past, and I wanted to make sure our audience was aware of the new recommendation. I'll pause for a second to see if there are any questions or comments. If not, we'll keep going. Okay, Simon, I don't see any. So what do you do if you get sick? Well, first of all, you want to stay home and away from others in your home. The new recommendation again is that you can go back to normal activities when you have been for at least 24 hours free of fever without the benefit of fever reducing medication. And overall, your symptoms are getting better. Both, not either or, both. And then you can go back to your normal activities. What would be ideal would be for you to practice your good hygiene, wear your mask during this time, because potentially you could still be shedding. So the mask is for the protection of those around you, not for your protection. And as we're getting into warmer weather, really lean on ventilation. And I know you're going to hear the theme of ventilation come up time and time again, because as we discuss all these respiratory viruses, because as these virus particles are floating around in the air in a contained space, it's very difficult to avoid them. But if you've got ventilation and air blowing through, it helps to minimize the density of the particles in the container, the room, and decrease the likelihood of your inhaling or transferring these droplets by touching your eyes or what have you. Next slide, please. Now, after those 5 days, when you have gone back to your normal activities, you still want to bear in mind the hygiene, the mask, and the fresh air and the distancing. They suggested, again, none of this was put in a terminology of mandate, that if you anticipate being around a lot of people, for their sake, test again to make sure that you are now negative. Because remember, you are going back out when you probably are not negative under these new recommendations. Next slide, please. Before Dr. Hines takes over, are there any questions at this point about COVID and the new recommendations?
What about Paxlovid?
It's still effective and available. If you get it, you can certainly take it. I mean, you can go get it, but it's not, again, anything that's mandated.
Is it recommended?
It is stated in terminology, it is available, just as the anti-flu meds are available. But they do not say run out and go get it. No. Okay, Dr. Hines.
All right. So now we're going to talk a little bit about influenza. So classically, flu season is from October or so to March. So historically, we would be coming to kind of towards the end of flu season. But as Dr. Nabert Stevens pointed out, no one told the viruses that their time is about over. Not to mention, I think that with all that's changing in our environment around us, some of the things that we've historically known to be true as far as the seasonality of certain things, things aren't exactly following the same pathways that we are used to. Again, rates remain elevated, but are overall trending down. And influenza A and B are showing about a relatively equal prevalence in this flu season, with a slight predominance of influenza type A. The influenza HRN2 strain is, in particular, more predominant. And there is the influenza type B that is circulating is of one particular strain, the Victoria strain. Typically, influenza A tends to be more severe than influenza B. Before COVID, influenza was the most common, regular respiratory virus that was killing people. And it still causes 21,000 deaths a year, 340,000 hospitalizations, and 30 million illnesses. And that's why there was a vaccination created for influenza, because while people loosely say, oh, I've got the flu, oh, I've got the flu, when you really have the flu, especially if you are in an immunocompromised state, it can be a very serious illness. Next slide. As far as the recommendations for who should get flu vaccinations, so everyone 6 months and older should get a flu vaccination every season, especially if you're someone who's at higher risk. And we've covered the definitions of higher risk. They're the same ones that we've been talking about for COVID. Ideally, you want even though flu vaccinations are available year round, ideally you want to get your flu vaccination closer to the start of the flu season. So as I said in the beginning, flu season usually starts around October. So you usually want to be vaccinated certainly by the end of October. What's unique about the flu vaccination is that every year there is a different concoction, so to speak, that goes into the flu vaccination. So what happens is all the healthcare tracking, virus tracking takes place, and they say what's going on in the eastern side of the world, and then usually what's going on in the eastern side of the world will kind of give us a clue as to what type of flu is going to come over to here. So usually in July, that's when they start manufacturing the flu vaccinations that are going to be for the upcoming flu season. So, which is one of the reasons why I said, while flu vaccinations are available year round, being strategic around, if you can, around when you get it makes sense. Because if you get a flu vaccination in May, yes, it was available, but it was for the previous season's, flu, right? So if getting it somewhere, at least after July, August, between that July, August, and October window is going to be ideal for the upcoming flu season, again, as best as our predictive technology can tell us, because here's what we also know. We can predict all we want. That does not mean that that's what's going to happen. People younger than 65 are, the CDC does not recommend any one particular flu vaccination over the other. There are several different types of flu vaccinations that are available, including, for those who don't like needles, a nasal spray version. And we've listed the several, there's the quadrivalent types of, quadrivalent means that quad is 4, so there's 4 different types of flu strains in that flu vaccine. And just to make sure that we are dispelling myths, it's not active flu. The flu vaccination isn't going to give you the flu. Usually, just like with COVID, what you get oftentimes after a flu vaccination is an immune response that tells you that your body responded to the flu shot. In addition to that, the other thing that I also like to remind people is 9 times out of 10, when you're getting your flu shot, it's also cold season in general. So the cold, it's very possible that you got a cold. It doesn't necessarily have to have been the flu shot that gave you the flu. Can go to the next slide. Signs of the flu. So signs of the flu are going to vary oftentimes by the age of the person who has, and by the age and some of the underlying, symptoms that or diseases or issues that an individual has. But the classic thing for classic flu is like, I was feeling good and then bam, right? It hit me. That's classic flu. And what hit you? These things here that we're talking about: fevers or chills, cough, sore throat, runny nose, body aches, muscle aches, fatigue, headaches. You don't have to have all of them. Oftentimes people will say, everything hurts, even my eyeballs hurt. That's classic. That's classic flu. And then oftentimes for younger people, you may get vomiting or diarrhea. Usually the flu, most people, when you truly have the flu, please don't be at work or please don't be elsewhere. But oftentimes you don't even feel well enough to be going around to go, do your regular activities. And if you notice, the flu symptoms often overlap with some of the other things that we've talked about already. Some of them can overlap with some of our, allergy symptoms. But again, when you fevers and things like that, high fevers, flu oftentimes comes with a high fever too. So, in the 102s, that kind of thing, that can oftentimes be a distinguishing feature as well. We can go, yep. So what do you do if you get sick? So stay home. You can go back to your normal activities after you've been fever-free and symptoms improving for at least 24 hours. Oftentimes people when you really have the flu, people underestimate how draining it can actually be. Classically, they'll say like a cold, you usually have your worst day somewhere between, day 3 and day 5. And by day 7 to 10, you're A-okay, right? Usually with the flu, you feel bad for at least a week, right? And it can take you 2 to 3 weeks to feel all the way back to your normal self. And sometimes, even though the fever's gone and you're feeling better, sometimes people get out there too fast and get out there and try to do too much too soon. The flu is truly, influenza can be very, very draining. But the key is, sometimes presenteeism is a problem, right? Whether that's, volunteer, where you were supposed to volunteer at, whether that was at your job, whether that was at a family function. Sometimes the best thing you can do is be absent if you're sick. We can go to the next one. And unless there are questions, I will toss it back over to you, Dr. Neighbor-Stevens.
Dr. Hines?
Yes.
Can you lay out for our audience the differences in symptomology between a cold and the flu?
So sure. In general, at the high level, if we go back to that slide that had the symptoms on there, typically colds may or may not give you a fever, right? And typically, if you're going to get a fever from okay, let's be clear. There are lots of different viruses that can cause colds, right? And the majority of which we don't have home tests for, and we used to just kind of, it's a cold and call it a day, right? So in general, colds versus the flu. Colds tend to give you a milder version overall of some of these same kinds of symptoms. Differences being Like I said, if there's a fever with a cold, usually a lower grade fever. A gradual onset of symptoms is usually more with the cold, when people go, oh, I feel a cold coming on. Like I felt it kind of, I had a little tickle in my throat and I felt the cold coming on, as opposed to, like I said, classically with the flu, it's like I was fine. And then it was like I got hit with a truck. I wasn't fine. That's classic flu. Both can come with cough, sore throat, runny, stuffy nose, body aches. The headaches associated with flu tend to be more severe than the headaches associated with colds, but both can cause headaches, fatigue, and tiredness. And like I said, I will also throw in allergies. So allergies can give you cough, sore throat. You might have headaches, right? You might runny nose, stuffy nose, sneezing. But what you don't get from allergies is fever. Without a doubt, you don't get fever from allergies. So especially around, depending on where you live, especially around this time of the year, it can be a little tricky to try to figure out what you have going on. But those are some key distinguishers that I tried to point out.
Thank you.
Mm-hmm.
Next neighbor.
Yeah. Simon, go back one, please. So the next respiratory infection that I'm going to discuss is not a new disease at all. The pediatricians on this call are very familiar with respiratory syncytial virus, or RSV. What has made it newsworthy in the past couple of years since the pandemic, there seems to be more disease seen in adults than we used to see. And at the same time, an adult vaccine came to market, which helped to shine a light on the disease. But in the United States, approximately 2.1 million outpatient non-hospitalization visits among children younger than 5 occur. And let me just say that the younger the child, typically the more severe the illness, with the most severe illness being seen in infants under the age of 12 months, and especially preemies. Now, part of this is because of the nature of the disease process. The RSV virus attacks the air sacs in the lung. The air sacs in young children, in babies, and especially preemies, are not nearly as well developed as they are in older children and adults. And so they have much less reserve, and it can be very devastating. We have had RSV vaccines now, oh goodness, at least maybe 20 years, time passes, at least 20 years. And the vaccine program started with giving the vaccine to preemies before they were discharged from the nursery, especially if they were going out into the community during the typical RSV season, which I'm going to get to in a minute. But it still didn't wipe it out. And with children in congregate care young children, especially being in congregate care situations, all you needed was for one of them to bring it home and it would wipe out the whole game. So that's why I kind of said with a smile, pediatricians are very familiar with this disease. And annually, there are between 58 to 80,000 hospitalizations in children younger than 5. What most people don't know is that most recent data is showing between 60 and 160,000 hospitalizations among adults 65 years and older from RSV. And usually that's because they have underlying pulmonary comorbid conditions. 6,000 to 10,000 deaths occur among adults 65 and older. So this is not just a cold we're talking about. This is a serious respiratory disease. And we typically have 100 to 300 deaths in children younger than 5. And I think the last statistic I saw, we were almost up to 300 for this season, so it may top it this year. Next slide, please. Now, in the good old days, RSV was seen usually between March and April. Those were the times that you were most concerned. However, during the pandemic, when there was isolation, there actually was less RSV seen because people weren't together. But now that the gates are open and people are back out and milling around, the rates are going back up. And with climate change, it's thought to be related to climate change, with the change in temperatures that is occurring. It used to be what I said, the September to April was true for everywhere except Florida and Texas. But now, since climate change has increased the temperature north of Florida, we are seeing RSV really all year. Not nearly as bad in the summer as you see in the fall and winter, but definitely it makes a presence in the summer. Next slide, please. I wanted to, I couldn't find a good chart, and so I apologize for the teeny weeny numbers at the bottom of this chart. So I'm going to cheat and tell you what I was trying to demonstrate. So at the extreme left end, we're beginning in March, the week of March 26th and 22. And at the extreme right end, we're talking about the last 2 weeks of March. And you'll notice that the line is gray. That's because the data is not complete yet. And I wanted to show you how RSV kind of comes in waves. So the blue line represents detection by antigen in labs, and the red is by PCR detections. Pretty much, give or take, they're about the same. So you can see that between November 5th and December 3rd of 22, we had a real spike in RSV cases. And then again, we had a spike where you have the blue line and the red line is not quite synchronous with it. That's November 4th and December 16th period. And that's when we would expect to see those spikes. That's exactly when you expect to see RSV. But notice in between those two, the disease is still around. It doesn't go away. Okay, next slide, please. So respiratory syncytial virus is a true respiratory pathogen. It is spread when people sneeze and cough. So if people spread the virus by sneezing and coughing, then you have to worry about breathing it and contact. And so you all know what to do. Wash your hands and wear the mask. This is especially true, I think, around family gatherings in the winter. I've said this before. When we get together at Thanksgiving and Christmas, ventilate as well as you can. Take those COVID tests before you get together. And then if anybody is sneezing and coughing, and you know you're going to have family members around that are immunocompromised or have underlying comorbid conditions which would make them more susceptible to very severe cases of these respiratory illnesses, remember them. And at the very least, keep your mask on if you must go. And then if you're one of those individuals, like, for example, let's say you're a grandparent and you've got young grandkids, and these young grandkids are going to daycare, and you can't handle pulmonary infections, get the vaccine and wear your mask when you're around your grandkids. And as much as you want to hug them and kiss them, that's not a good idea. Next slide, please. So how can you prevent it? RSV immunizations are recommended for only 3 groups. They are recommended for adults age 60 and older. Is someone asking me something? Okay, I guess I was hearing an echo. Pregnant women. There is a real drive now that there is this vaccine available for pregnant women to get them to take the vaccine to protect their baby once the baby is born. And then infants and young children who have pulmonary issues, congenital heart defects, conditions that make any kind of respiratory compromise difficult for them to handle. Next slide, please. So how do you know you have RSV? Well, there actually are some tests for RSV, but the symptoms usually come on within 4 days of your getting infected. And the symptoms, I bet you wouldn't guess, are runny nose, decrease in appetite, coughing, sneezing, fever, and wheezing. We're kind of painting a picture here, aren't we? Next slide, please. So we're at the point, Dr. Maxey kind of jumped the gun. We have the symptoms. We've got the fever, we got the sore throat, maybe, and some nasal congestion, runny nose. What do I have? Because I need to know what I need to do, right? Next slide, please. I'll turn it over to Dr. Hines since she's got this down.
So, as you try to decipher between all of these different things, and here's just a little cheat sheet here. So let's talk about the colds. In general, colds overall tend to be the mildest version of this constellation of symptoms, right? So some of the things that they all seem to have in common, if you look across the board, are going to be the cough, the runny nose, plus or minus sneezing, sore throat. And then as you look across, flu can, as we talked about before, colds are kind of gradual onset. Flu tends to be sudden and tends to be more severe. RSV tends to be more of a gradual onset, but it can cause typically causes more severe symptoms in young children and older adults. And then COVID-19, as we know, can run the full gamut from mild symptoms to severe symptoms. Some of the things that are a little bit unique or that you should take, certainly more seriously if you're talking about, I'm just gonna, treat it at home and wait it out, is when you look at things like wheezing, right? So if you're not someone who normally wheezes because you have, asthma or COPD, and you don't have any inhalers or anything to treat the wheezing, right? That's something that you certainly want to be checking with your doctor about, right? Because wheezing can be something that comes along with some of these colds and some of these viruses, but sometimes that can be the precursor to more serious symptoms. So that is wheezing is an indication that air is not flowing smoothly for whatever reason. And then sometimes it can happen, because there's mucus in there and you can cough and the wheezing goes away. But if it sticks around, and that's not something that you have any remedies for, definitely something to go get checked out. Then the other things too that can tell you, can kind of help you figure out whether or not I need to go seek care for this, because again, most of these are going to be things that, if they are on the milder side, you can treat with what's called symptom management. So that means some of your over-the-counter remedies, your home remedies, rest, fluids, that kind of thing. When you're talking about things like diarrhea and vomiting, if it's getting to the point where it's coming out, however it's coming out, faster or in a higher volume than what I can take in, that is a reason to go seek medical care, right? Even if you thought it was just one of these, it's just the virus or whatever, stomach viruses happen, right? And they can cause you vomiting and diarrhea, some of these other things in Constellation too, or at least in the Maryland area. There was a virus going around in the recent weeks that was causing significant diarrhea and vomiting, but it also came with, upper respiratory symptoms as well. And then, like I said, most of these, some of the things that distinguish them are kind of the onset and the severity. Many of them, if they are treated at home, can be treated with some of the same types of things. But the things to watch out for are the things that you're not really that if you're dealing with them at home and they are overwhelming you, meaning I'm not able to catch my breath, I'm not able to get this vomiting or diarrhea under control, I'm not able to hold anything down, regardless of what you think the underlying cause is, that's a reason to go get some medical care.
Next slide, please.
As we talked about before, or is it allergies? One of the things that we pointed out before was that allergies. Sorry. Yeah, come in. That's fine. I'm on a call. Allergies historically do not cause fever. So that can be a distinguishing characteristic when you're trying to figure out which one of these viruses that you have. So if you have fever, that is something that's going to let you know that that's not your allergies. And we need to go down a different course, and you need to treat it differently, because oftentimes, especially when you're talking about, kids in school and how long to be out for, sometimes when you've got allergies, that can go on for an extended period of time as far as the postnasal drip and the sore throats and the cough are concerned, right? And you can't be out of school for the entirety of spring while we're getting our allergies under control. But if you've got some of these other, and allergies does not come with vomiting and diarrhea, right? There's certain things that even if you wish it was just your allergies because it's that time of the year, take a comprehensive look at what's going on so that you can make the right call as far as what you should or shouldn't do, where you should stay, not stay, and whether you should seek medical care.
And with that, we open the floor to questions and comments. Dr. Maxey?
Thank you so much. This was so great and so useful to all of us, me included. Is there anything in the chat, Dr. Walks, that we need to talk about, or you want to start with questioning?
I don't see anything in the chat, Dr. Maxey. I have a question though. There are a lot of times when someone is around me and they are sneezing and the nose is running and they, I guess, taking some cold medicine, so they look like they're a little down. And as I begin to back up, they say, "Oh, it's just my allergies." And in the back of my mind, I'm saying, "I don't believe you. I need to get away." So, how just in terms of interacting with other people, should I snatch my mask out of my pocket? Should I back away? What should I do in those situations?
Who are you directing it to?
I'm directing it to whoever has the answer, because this time of year, it's actually not uncommon that people are walking around and the first thing they say is, "Oh, it's my allergies."
Well, I think it can be tricky, right? Because on the one hand, first and foremost, you don't have to believe anybody, because who said that they knew that they diagnosed themselves correctly, right? So I think at the end of the day, it's easier when it's a stranger, right? And then because then it's easier to go and put your mask, grab your mask out your pocket if you didn't already have it on, and be like, oh well, just to be on the safe side. But ultimately, that's really what you should do, assuming that it's in a situation where you can't remove yourself from that other person's presence. Because again, lots of times people mean well, but they just didn't know, right? Because again, I thought it was allergies, especially when we were talking about the gradual onset of a cold, right? So the gradual onset of a cold can look like, allergies or things like that in the beginning before it has fully kind of declared itself as a cold. So you don't have to, in the same way that you didn't have to put your health in anybody else's hands in various other circumstances, you don't in this one either. I think and Dr. Neighbor-Stevens can really speak to this one. I think this one, especially with school age kids, this one can be really tricky when you're trying to get kids to go back, to be able to go back to school. Because sometimes it is allergies and you're doing all the things, but they're still, symptomatic, so to speak. Any thoughts on that one?
I do. First of all, I want to say that allergies are year-round now. Again, it's felt that this is due to climate change and temperature change, which allows different things to grow at different times and pollinate and do what they do that trigger allergies, not to mention molds and dust. So just because it's you have allergy symptoms, you cannot assume that that's what it is. I don't have as diplomatic a response as Dr. Hines as usual. My thing is, you are the one that has to take care of you. And so you need to figure out what's best for you. If you don't have time or want to go through either RSV, COVID, or even a cold for that matter, then put on your mask. I keep masks with me. If I am in an environment that I feel there's enough space, enough room, and enough ventilation that I can be comfortable, I don't put it on. But as soon as I find myself in a situation where, as the old folks used to say, it's too tight, I put that mask on.
Let me ask you a question. Why do you think that the CDC did not further want to introduce the virucidal agent anymore, the Paxlovid? Is there a scientific reason that's been talked about?
Well, I don't mean to misrepresent the CDC. They list Paxlovid and all the other antiviral medications as things that you can do, possible treatments.
But they don't recommend it necessarily.
It's not a question of recommendation. The statement is such that if you have X and drug B is available, drug B is available to treat this. They're not saying that they don't recommend it. They make it quite clear that these treatments are available.
So there is a question in the chat related to that about the medications for flu and COVID and what are the latest guidelines. And so it sounds like the guidelines are still that the medications are available, but they're not saying to go and get the medications.
They
It's
weren't
still
real
not clear.
strong on Paxlovid. Go in and get into Paxlovid if you really think about it.
So the answer to your question, Dr. Maxey, is the answer that we always got from our colleague, Dr. Jordan, who said, basically, you need to have a doctor that you can talk to about what's best for you.
Right. In the meantime, I would think using common sense, if you're older, if you're immune compromised, and if you have any, especially symptoms such as wheezing, etc., use common sense and ask your physician, is COVID something you should do? And not COVID, but Paxlovid.
Well, the other thing that I would say is that, as I said to Dr. Walks with his coming up in contact with somebody who said they had a cold, you have to not only know your physical condition and risk, but you also need to know what your lifestyle is going to be. And where am I going with this? What I'm saying is, if you anticipate that you're getting ready to do travel, especially out of the country travel, where you don't want to get sick and not be so far away from home, you probably should consider getting the immunizations that you think you are in need of, or want to guard against diseases while you're traveling. If you are going to be taking care of a family member who is elderly and frail, you might want to think about whether or not you need to get certain immunizations so that you don't put them at risk. So it's an individualized decision.
Well, thank you so much. This was an excellent presentation and review. This is great. We'll have more of these. Thank you, Dr. Neighbor Stevens and Dr. Jocelyn Hines. This was great. What do you think, Dr. Walks? Was this good?
I think this was very good. I'm going to have to give it serious thought, Dr. Maxey, since you invited everyone to come to Beaver Creek, Colorado. I'm going to follow Dr. Neighbor Stevens' advice on preparing to travel. I'm not sure if there are a whole lot of emergency or urgent care facilities in Beaver Creek, Colorado. We do have a question. Cheryl Holder has her hand up.
Dr. Holder. Can we unmute her?
Now I got it. Okay. Yeah. Thank you for that recommendation that you had when you take care of very elderly people, because a lot of folks don't remember that they need to protect the folks that they're caring for at home. And especially with the 60s and 65-year-olds, which are the bulk of the folks taking care of the very elderly, and they're resistant to getting RSV and all the other vaccines. So it's real important that we push that as one of the reasons they should be vaccinated. Because when you look with RSV, it's most people who really don't do well are over 80. If they have no underlying, they're much more the very elderly. So they really have to be vaccinated. So it's such resistance to getting vaccines lately that we have to find every reason to let folks know that they need to protect the very elderly that they care for.
Thank you.
Thank
Well
you.
said.
Dr. Hines, why don't we go with final words?
Well, just to recap, I think the thing about it is there are a lot of different things circulating around, and we don't have tests for readily available or easily accessible for all of them. So that takes us back to our recurring theme here at the Black Health Trust around common sense. You know, if you think that you're sick, if you have symptoms of illness, right, keep them at home. Keep it to yourself, and then, you know, do all of the things that you can, as Dr. Holder pointed out, to not only protect yourself, but to protect those around you that you love and care for, including the neighbors and the people at your church that you may not necessarily know by name, but you didn't mean to get any of them sick either.
Thank you very much, Dr. Holder, and thank you for your excellent participation as usual. Dr. Neighbor Stevens.
Well, my hope is that the information that we've shared with you today is helpful and will aid you in making the best decisions for yourself and your family as you can.
Thank you very much, Dr. Barbara Neighbor Stevens. As usual, you give us real good advice.
So Dr. Maxey, I do have a closing comment. One of the things that just occurred to me is that as we're talking about folks going out and as Dr. Holder talked about protecting the folks that we are trying to take care of, now I'm not a family practice doc, but I think this is accurate. If I'm already sick and I'm fighting something, am I not at higher risk, Dr. Hines, for catching something else?
Oh, 100%. If
Okay.
your system, if it's what it's always been, if you're not in the best shape that you can be, when the next time a germ of whatever form goes on to attack, you're not well suited to fight it off. And whether or not that is, sick or down because you're stressed out, because you're not taking care of your body, because you're so busy taking care of someone else, because you already have a cold, because you have some other things that are untreated, it makes you more, all of those things can make you more susceptible to any of these viruses, germs, cooties, whatever you want to call them, when they come a calling.
So common sense would be if I'm not feeling good for any reason, whether it's allergies, whether it's RSV, whether it's COVID, I don't want to be one of those people that is calling from the hospital saying, the doctor told me I got COVID and RSV and the flu, because that can happen,
It
correct?
does. It absolutely does. It absolutely does.
Okay. That's my final comment, Dr. Maxey. Now I'm worried. I might not go out again until June.
Well, my final comment is GMO and keep your mask handy. I keep a mask in my pocket at all times. And like Barbara Neighbors-Stevens, I may put it on. So you want to keep it handy. And it is important to protect other people as well. So keep it with you in your purse, in your pocket, or wherever is safe. Have a great Sunday, everybody. Thanks for joining us.
Good day, everyone.
Bye.
Bye.
Thank you, Simon.